Rahman Rahim. Our case today is common in Arab board, Saudi board, Jordanian board, and Egyptian board. This is cardiac case. We'll see our case today. During regular check-up on an 8 years old child, you know, this is the first clue. Loud first heart sound with fixed and wide split second heart sound at upper left sternal border that does not change with respiration. This is the clue from this question. This is wide, fixed, split heart, second heart sound at upper left sternal border and does not change with respiration. This is ASD. ASD, and the patient otherwisely is active and healthy and asymptomatic. The most likely heart lesion to explain this finding will see ASD. So this is the case of ASD. This is characteristic for ASD. Loud first heart sound with fixed and wide split second heart sound at upper left sternal border does not change with respiration. Does not change with respiration. So this is the case of ASD and characteristic of ASD. So the ASD is the most common form of ASD, and also consider there is left to right shunt, and mostly it will be asymptomatic, and the characteristic feature of the ASD second heart sound is wide fixed split. Wide fixed split at upper left sternal border does not change with respiration. Does not change with respiration. So this is the ASD. Most commonly, it will be asymptomatic, and the lesion found during routine examination. Routine examination. And in older children, there is exercise intolerance can be noted if the lesion is significant size. Significant size in older children, it will associated with exercise intolerance. On examination of the baby with ASD, the pulse are normal, having right ventricular systole left at the left sternal border is palpable, and this is the most characteristic features of ASD. Fixed splitting of the second heart sound is audible. Fixed splitting of the second heart sound is audible. For less degree of the ASD, surgical treatment is more controversial. The surgical treatment is controversial. But what about the VSD? The VSD, it's common present with harsh and blowing whole systolic murmur. The best heard were left lower sternal border, left lower sternal border, and often with radiation throughout the precord. So the VSD, it will be harsh or whole systolic murmur, the best here lower left sternal border, and can radiate throughout the pericardium. What about the tricuspid regurgitation? Is mid-diastolic rumbling murmur at the lower left sternal border, and often there is history of birth asphyxia. There is myocardial function defect on or finding of other cardiac lesion are present. So the tricuspid regurg, it will be mid-diastolic rumbling murmur, lower left sternal border, and there is history of asphyxia or perimeter asphyxia. Why? Because the myocardial function, it will be affected. Also, there is sometimes it will be associated with other cardiac lesion. But what about tetralogy of Fallot? This is very common form of congenital heart disease, and this called tetralogy. This means 4 abnormalities. This is right ventricular outflow obstruction, VSD, and dextroposition of the aorta, and right ventricular hypertrophy. Right ventricular hypertrophy. Cyanosis present in infancy, you call it cyanotic spill, and also it will associated with cyanotic spill. This is tetralogy of Fallot. What about mitral valve prolapse? It occur, it's flowing into the aorta of one or both mitral valve leaflets at the end of the systole. So it will, the mitral valve leaflets, it will be affected during or at the end of the systole. These congenital abnormalities frequently manifested only during the adolescent or later. It will be later. Mitral valve prolapse, it will be in adolescent or later. And it's more common in girls than in boys, and seem to be inherited as autosomal dominant fashion. This is mitral valve prolapse. Mitral valve common in girls, and there is seem to be inheritance as autosomal dominant fashion. On the clinical examination of mitral valve prolapse, there is apical murmur is noted in late systole, which can be preceded by mid-systolic crack. can be preceded with mid-systolic click. So diagnosis, how to confirm diagnosis of mitral valve prolapse? By echo. It showed the prolapse of the mitral leaflets during what? During mid to late systole. Mid or late systole. So there is a prolapse of the mitral leaflets during the mid to late systole. Shall we give antibiotic prophylaxis to prevent the endocarditis? Yes, this antibiotic prophylaxis is recommended for dental work, especially if murmur is present, as incidence of endocarditis can be higher in this patient, So put in your mind our clue in this question. This is loud first heart sound, fixed and wide split second heart sound at upper left sternal border, does not change with respiration. This is ASD, atrial septal defect. It will be asymptomatic. It will discover with routine examination. It will be left to right shunt. Characteristically, fixed wide split second heart sound at upper left sternal border, does not change with respiration. ومن أحيا فكأنما أحيا الناس جميعا. شكرا، سلام عليكم.